let's turn our attention to some evolving data. You know, in kidney cancer, we've spent a lot of time looking at advanced disease. We have targeted and developed many drugs over the last decade in metastatic disease. And for the first time, Michael, we're starting to see some evolving data that suggests that in high-risk resected disease, before a patient has metastatic disease, there might be some benefit for some of the therapies that we've used over the last decade. And it's a bit confusing because it's conflicting. We have data from Assure, we have data from what's called S-TRAC, which I'd ask you to describe, and most recent data from PROTECT that came out just at this 2017. So let's start off with where is the field, as you understand it, with respect to high-risk resected kidney cancer in the absence of metastatic disease, and then we'll expand it to other panel members about their thoughts.
Sure. So I agree it's confusing. There was great excitement when the VEGF inhibitors were first tested in kidney cancer in patients with metastatic disease, and we saw significant prolongations in progression-free survival, and overall the survival appeared to be prolonged over what it was when we were using cytokines. And so there was a push to try to move those therapies quickly into the adjuvant setting to see whether we might have a similar impact. And there was always a question about whether targeting a treatment that really delayed progression-free, using a treatment that delayed progression-free survival but didn't produce durable responses except in the rare patient was going to really be able to have an impact in the adjuvant setting, because the hope had to be that when you were treating patients when they had smaller tumor burdens and less heterogeneity in their tumor, that by giving an active drug that targeted blood vessels rather than the tumor, you could somehow get rid of the last tumor cell and produce some cures. And there was, we used to debate all the time whether that was possible or not. And we all hoped that at least there would be a delay in relapse-free survival. And in the Assure trial, which was the first one to report out, which randomly assigned patients to either sorafenib, sunitinib, or placebo sunitinib or sorafenib, and there was a comparison of both of the active treatments to the placebo group without comparing the active treatments to each other. There was really no benefit in terms of either relapse-free survival or overall survival in a study that involved 1,800 patients for either sunitinib or sorafenib. And the treatment was given for a year, and the time to relapse was somewhere around 5 or 6 years. There's for median, and so it's possible there might have been some early subtle benefit that was lost when you stopped the treatment. And in that study, a lot of patients didn't tolerate receiving these drugs in the adjuvant setting. There was some toxicity, so many patients stopped before they got their full year of therapy. And so there were a lot of explanations that were put forward, but the overall feeling was there was not a home run. The S-TRAC trial, which looked at sunitinib compared to placebo in a higher risk population, therefore a smaller study to get the same number of events, did show a small benefit of a few months in terms of relapse-free survival benefit, but no benefit in terms of overall survival. And the question is that really worth the toxicity of taking that therapy? And the PROTECT trial was probably closer to the Assure trial, showing not much benefit for the intent to treat population for pazopanib compared to placebo. And we actually went back and looked at the Assure trial and tried to identify the type of patients who were on the who would have been eligible for the S-TAC trial in the Assure trial, and tried to reanalyze the data to see whether or not we could turn it into a positive trial by focusing on a different subset of patients than was in the trial as a whole. And no matter how we analyzed it and tried to narrow it down, there was still no benefit for sunitinib compared to placebo. And so my sense is there may be some delay in relapse-free survival that happens with these treatments, but in the majority of patients are not having their disease go completely away. And when you stop the treatment, the tumors tend to catch up, and there ultimately will be no difference in overall survival.